and partnered with me, partnered with my patients. And we love doing this. You know, people ask me, why do you love being a pain physician? And I always tell my patients that it reminds me of a story that even before I went to medical school, I was in a social gathering and I basically said, how many of you in the room don't have any pain at all? And there was literally nobody. Everybody had pain. And I thought to myself that this is crazy. You know, if so many people are in pain from headaches to back pain to leg pain to abdominal to pelvic, then I really need to do something. And that kind of sparked a thought process in me. And here I am, you know, interacting with all of you at the clinic level, at the surgery center level, and basically partnering to help you out. Today, my goal is to talk about some of the key things we see if you have back pain. And I want to emphasize on one thing. We are not in the era of talking about, oh, I have back pain and that's it. Think about it from this point of view. If you had pain in your abdomen, would you just say, oh, I've got abdominal pain? Or would you actually go to a GI doctor and say, hey, I want to know, is this my gallbladder? Or is this my appendix? Or is this my bowels? But you really get down to the nitty gritty and dissect it down and want to understand, where's the pain coming from? It is the same scenario for spine pain. When you come into my clinic or see me or anybody from my team and you say, oh, doc, I've got back pain and I've got, you know, yes, it goes down the leg. To me, that is a very generic term, but that's really when the journey starts. My goal is to dissect that back pain down into what is really causing that back pain. So that's number one. Number two, I'm going to talk about, and I want to get this notion out of everybody's brain and mind today, that you have to live with pain. Our nervous system and our body is accustomed, or the way we have evolutionalized ourselves is that we're adapted to live with a little bit of pain, but not with too much of chronic pain. And we all have pain. I've got pain. I'm sure Lucius, who's on the show here, he has pain. Everybody has pain, but we have adapted ourselves to live with that little bit of pain. What happens is that a lot of patients in the community sit on their pain. They accept the fact that pain is part of their life. And by the time I get to see them, it's like chasing the bus or chasing the train, whatever you want to call it. So we're going to talk a little bit about that, so that I want to educate everybody that there are options out there. But that's not the point. The point is that we have to act on them early. And so like you would jump and go and see your GI doctor for abdomen pain, or your GYN for your pelvic pain, or your neurologist or your primary care for headache pain, if you have chronic pain anywhere from head to toe, we're there for you. We want you to at least come in and have a discussion. You may choose not to do therapy A versus treatment B versus C. That's a different story. But I think our primary goal in the community is being education. And I'm big into education, and that's where we're going to start off from. Next slide, Lucius. So again, like I said, we're going to talk about chronic pain treatment options. And I want everybody, and some of you may have already listened to these options and call them injections or surgeries, but we're going to recap things about the spine pain. And then I'm going to tell you a little secret as to why we always do and talk about treatments centered around the spine. Personalization is important. One of the key things I learned from my patients very early on in my practice, as you guys know, I started practicing in the Killeen Temple area about 9 years back. And the first thing I learned in my first year of practice was that we need to partner, but we need to personalize pain management. And so people came in and said, oh, you know, I'm a veteran and my PCP thinks it's in my mind. And I know it is not in the mind. I know there is pain there. And if there is pain there, there has to be nerves. And if there are nerves, then those nerves can be numbed up or blocked so that the brain doesn't perceive that as pain or painful. And then we're going to talk a little bit about, if you can really block that nerve, then there are ways using milder forms of electricity, like a battery, you can actually tame that pain to your personal tolerance. And that's called personalization. And then there's a lot of things we can talk during appointments. Again, you know, maybe this is not the right time, but we can do a telemedicine visit, et cetera, et cetera. But there's various ways. As you guys all know, I'm probably one of the only physicians in the area, in the entire Austin area, and maybe 100 miles around there, where patients have access to my cell phone. And we're going to make sure that everybody gets that. And you can call me anytime. If I'm busy, or if I'm in the operating room, or if I'm doing busy with the patient, somebody from my team will reach out to you. And so you have direct access to me 24/7, 365. Just be careful, I sleep at 10 p.m. So next slide. So first of all, I want everybody on the call to understand that pain is not just one word. It's not about, oh, I have back pain, and then there's this magical switch somewhere where the pain doctor is going to just switch it off and you're done. No. We need to understand that as you develop pain and it becomes chronic, what does chronic mean? That means if you've had surgery or if you have back pain over time, multiple pain generators crop over in the spine. And so different things can cause pain. For the purpose of spine pain or back pain, we like to kind of differentiate between mechanical. That means, if you were to do things, you develop arthritis in your spine, that's mechanical pain. That everybody has that. And as you get more and more wiser in life, the 5th decade, the 6th decade, the 7th decade, that pain becomes more prevalent. It is usually in the back, it stays in the back, kind of goes into the leg once in a while, and usually we'll do different things for it. Then there is neuropathic pain, which means nerve pain. And ultimately, all pain becomes neuropathic, which means pain which is transmitted by the nerves to the brain. And what does that look like? So you could have a little bit of weakness, your legs may give away, you're coming out of your car, you're coming out of your bed in the morning, you can feel pins and needles. But usually it's burning, shooting, stabbing. And most of the time it gets worse when you're trying to do things which are important for you, right? So you're trying to take your kids for a walk, go to the school, do household work, etc., etc. Next slide. So one of the things, why should we jump onto this? Why should we say, or when should we say, I'm having pain, I need to go and see a pain physician. I'm not going to basically be played like a tennis ball from one specialist to the other. If I'm having pain anywhere from head to toe, it makes sense to at least have a visit. Now, I may decide, based on our consultation or mutual decision making, that look, now's the time to see a neurologist, now's the time to see an endocrinologist, now's the time to see B, C, D, E specialist. But I become the primary care physician for your whole body pain. Okay, so when do you think you should initiate that? When you're not able to perform basic tasks around the house, right? You're cooking and dishes, etc., etc. The ability to work, go to work, right? Or doing other things. Now, a lot of my patients are female patients who are homemakers. That's hard work. So for them, that's work. Playing with children and grandchildren. If you're in your 5th decade, the 6th decade, the 7th decade, the number one thing which frustrates you as a patient, and I know because my dad was in the Army and I can totally see it. If he cannot play with my kids, then he gets frustrated, right? So those are the things. Sexually active. These are activities of daily life we have to resort to if you're young, if you're these are the basic necessities and pleasures of life. Gardening, arts and crafts. I mean, these are things which we all enjoy doing. Outdoor activities, right? I'm a big outdoor guy, but if you're having chronic pain, you can't enjoy that. So if any of these things are interfering in your life and your mood, then that's the time to talk to your primary care or come straight to a primary care physician. You can call us. We can arrange a primary care physician visit if you need a referral. We want to be the one-stop shop. We've always been like that. And we respect our troops, our veterans. Like I said, my dad is in the Army and I understand chronic pain very, very well. Next slide. So you probably tried all of these things. I don't need to go into all of these things. You've tried anti-inflammatories. That's where most patients start. That's what I would start if I have back pain. Physical therapy, I think, is key, right? The Army recognizes it. And if you're a non-forces or non-veteran, physical therapy is the first thing we should do. If you haven't done already, let us know. We can arrange a referral. Your primary care physician can arrange a referral. Simple things like using a tint unit. Doesn't help everybody. You probably not a bad thing to try. Some people are on medications. If you go to a primary care physician or other pain management doctors, sometimes they'll give pain medicines. Not a bad thing to start off if it's a small dose. Not a bad thing at all if you're maintaining your pain with a small doses. The problem happens when you start relying on them, right? And sometimes it's out of your control. You may want not to take those medicines, but those medicines want to take you. And I think that's the key principle we need to understand. One of the secrets I'll tell you, when do doctors write opioids? When they reach a roadblock. So if you are with a pain physician and the pain physician says, well, let's try some OxyContin before we can talk about treatment, then that should raise a radar light that maybe the physician is not that experienced to offer advanced therapies, advanced treatments. Like I said, small doses along with other things, not bad at all. It's a four-legged stool approach. There are four legs in the stool, right? So one of them could be therapy, one of them could be advanced interventions, one of them a little bit of medicines, and a little bit of other things. And then of course you can have surgery. If you've had surgery and you continue to have pain, we should be the first one-stop shop. There's a lot of things we can do and maintain your pain. Why do I use the word maintain? Because it's not an on and off switch, it's a dimmer. So we're gonna dim the light and then slowly the light is gonna basically glow back. We're gonna dim it back again. And these are the things we can discuss. It's like managing chronic diabetes. Next slide. So let's talk about the three things we can do for you. And why do I narrow down to three things? Because these are the main things or the main pain generators we target. So radiofrequency ablation is something very common I do. It's something very simple, right? If you have mechanical pain, arthritis pain, pain across the back, and you've been an overactive person or a normal active person who has pain in the lower back, we go and do a little test injection. Now it's injection, it sounds horrifying. I'm getting injection in the spine, but we use an X-ray. And it's not in the spine, it's kind of right outside the spine on the joints of the spine, which bear the brunt when you're walking and running and being active. And simple local anesthetic treatments of that joint can really make you functional. What happens if you get a few days of relief after that? You say, doc, it worked great, but no good, didn't last. Because we haven't done the long-term treatment. It's a test injection. It's like getting a blood test and then working on it. So this is not a blood test, but we put simple injections, get a result, and then we can basically, people use words like freezing the nerves, burning the nerves. I use the word ablation, and I like to use the word ablation in a scientific because I want everybody on the call to understand that we're using radio frequency and we basically go ahead and ablate those nerves. Now, it doesn't mean we burn the actual nerves. There's tiny sheets around the nerve. We actually radio frequency effect ablate the sheath around the nerves because it is that little sheath around the nerve which carries the pain signals. And then slowly the sheath is gonna grow back. And what is that time? It could be 6 months, 9 months, year and a half, 2 years. And you could be anywhere in between. But one of the key things which we have missed is as people become more and more wiser in life, or if you've been active duty, you've had a multiple traumatic injuries to your spine, you may develop a condition called spinal stenosis. What that means is that you may actually narrow the areas in your spine. And when you narrow areas in your spine, it causes a very unique kind of presentation. That means if you were to go grocery shopping, you have to use a shopping cart. You have to lean over to the shopping cart. You have to make sure that you are leaning over it so that slight leaning forward helps open up the space and carries on. If you're doing things at home, you have to sit down. You have to sit down and rest because if you don't, your back and legs start hurting. So you rest on. I have patients who would keep a chair in the kitchen, or they will lean over the countertop, or they will rest against a wall when talking to a family member. So all of these things give a clue. So if you see a family member walking with a cane or maybe a walker or leaning over or bending over to get some relief before carrying on with their daily activities, let's not wait. The spine is a ticking time bomb. Let's not wait. Come over. We'll help you design a plan for you. But most people, fortunately, are not in the severe category. They're in the between zone. That means they're mild or moderate, but pain is severe enough to compromise their functions. We can put this tiny spacer, which is right outside the spine, in your spine. So if that's your back, and those are your spines you feel on your back, we can go at the target level. We can make a tiny little poke and go in with a little instrument and dial like a screwdriver, a spacer, which is going to open up the space. So it's going to open up the space. So if it's closed, it's going to open up the space at that level, and you're going to feel great about it. Here's the beautiful part. That spacer does not disturb anything inside the spine. So let's say fast forward 5 years, 10 years, if you were to have a surgery, it doesn't basically interfere with any of the dynamics in the spine. And it is completely reversible. So you can actually go back in and take it out and as if nothing had happened. One more thing, if you have chronic pain, which is nerve pain, you've had surgery, or maybe it's not as bad to have surgery, you don't have to wait in pain, which has an effect on PTSD. People get angry. Psychologically, we don't feel good. Imagine those days when you're angry or when you're in pain, you don't sleep well, you get depressed. I tend to get angry. I'm sure you guys tend to get angry because that's what chronic pain does to us. If surgery is not an option, which in most cases that's true because it's not severe enough to have surgery, we can actually do something called a spinal cord stimulation. Now, spinal cord stimulation sounds like a horrific scientific big word, as if you're going to do something to your spinal cord. We actually don't do that. We put two electrodes, which is no different than putting epidural catheters in ladies who are having babies. Now, it's not an epidural where we are giving medicines to numb you if you're having a baby. It's the same concept. You're outside the spinal cord. You're in the layers covering as in the area outside the spinal cord. You gain access. You do a test drive, and that's the key here. So if I feel, based on the science, that you are a candidate who have exhausted some of the other things and in chronic pain, we can just do those shots and put those catheters, send you home for a week, and you can test drive this. You can test drive, come back in a week and say, Dr. Mehta, this was great. For a week, this was the best week I've had. We could sleep, we could walk, we could do things, and I really felt like a new person. Now, science says that we look for 50% relief, but I have patients coming in 70%, 80%, 90% relief. And Lucius will tell you that, when he's involved with a patient, that these patients are coming in, they've never had that week before ever in their life. So then the question asked is, what happens if the trial doesn't help? Well, if the trial doesn't help, it's not that we have made a surgery and you're stuck with a few other things. What it means is that you have tried a therapy which could change a life for you. Now, I've had a couple of patients here and there who have not had any relief with a spinal cord stimulator trial or a neurostimulator. I like to call it a pain pacemaker. And we're back to where we were. And we don't have time now, but that's a separate discussion in an office visit. There's a lot of other things we can do to manage your pain at that stage. Most patients, I would say my trial to permanent success has been close to 95 to 99%. All these patients do very, very well. Now, what happens once we have implanted? What does that mean? We put the same leads back in. This time we'll make a small incision somewhere in the buttocks and put that small battery or that pacemaker up there. So like a heart pacemaker stays away from the heart and kind of controls the heart for a variety of things, pain pacemaker actually stays far away from the spine and can control the spine pain. And so again, all of these things are completely reversible. So for some reasons, if things worsen 5 years, 10 years forward, and you need a surgery, this can be taken off. So there's a variety of things which can be done. Next slide. A quick little, for the next 5-6 minutes, I want to talk about what radiofrequency is. It treats pain in the back, the knees, the hips, and the neck. You do a simple shot, put a needle close to where the nerve is, look under X-ray, and you can go ahead and do, like I said, a chest injection. And if it helps, then you can go ahead and ablate these tiny nerves. These are not the main nerves. These are the tiny nerves. And basically, this can be repeated. It is a steroid-free treatment. It can be repeated in 9 months, 6 months, a year, depending on your insurance. Next slide. What is the Vertiflex? That's the spacer I was talking about. So look at the spine. It's outside the spine. Those are the nerves getting pinched. Next slide. And how do you know you're a candidate for this? How do you know your mom is a candidate for this? How do you know your grandfather is a candidate? How do you know your neighbor is a candidate? When I see patients walking in using a shopping cart, leaning over, they have to sit down all the time in between their tasks. And when they sit down, they feel better and can carry on. That's the person I feel obligated to at least discuss this therapy, because I don't want them to think that this is something they have to live with. Pain, of course, when walking and standing. Now, there are things we can discuss during an office visit and et cetera, as to when is the right time to do this and are you a candidate or not based on your MRI. But those are the things. If you see a family member suffering like that, then don't sit on it. Don't stay quiet. Next slide. What is lumbar stenosis? We talked about it. You can see here the red zones where the nerves are getting pinched. You have a healthy nerve, right, which is the blue. Then you have the disc, which is crumbling, which is basically wear and tear, right? And you see here that arthritis, combination of a poor disc and arthritis can cause that. And so pinched nerve, we all have that. If you have back and leg pain as a result of aging or trauma, we have that. And so that's called stenosis. And if it's not as bad to have surgery, which is the big chunk of patients I see in my practice, then you have a minimally invasive option. Next slide. And that's the Vertiflex procedure. It's FDA approved, right? So the carriers pay for it. The insurance carriers pay for it. It's a very standing, so same day procedure. So it's not a surgery. It's not having a big surgery. It's a same day procedure. You come in, and then you basically walk out after the procedure is done. It does not require removal of any bone or tissue. There's a very low risk of infection, and it actually can provide a long-term relief based on data. So there's enough research done, and the research was supported by the FDA, and based on which you got the FDA approval. And a lot of patients have been treated in my practice, in the country, nationwide. Next slide. And so, look, if you look at the results here, you can see here that 90% satisfaction, right, which is key to my patients and to me. You could actually drop the dose of medicines. And so when your doctor says that, well, you cannot have a certain dose of medicine because of the laws and the state laws, then that's when you basically use these therapies to wean those medicines to the level which are safe for my patients. Improvement in physical function, and there's a dramatic drop in the leg pain and back pain, especially if you have spinal stenosis. Next slide. Now let's discuss spinal cord stimulation. We talked about it, right? Those electrodes, those leads which you can put in like an epidural catheters, and there's a variety of pacemakers you can use. Next slide. And so who can benefit? I'm going to quickly recap this here. People who have nerve kind of pain in the back and the legs, definitely people who have had back surgery, because there's really nothing left there now. You've already tried a back surgery. The second back surgery, unless and until is really needed based on your spine doctor and your MRI, is not going to take care of your pain. So what I do is I manage those patients in consultation with my spine surgeons I work with, or neurosurgeons or orthopedic surgeons I work with. If you've been in chronic pain and you've been seeing a pain specialist for 6 months, if you have pain in the back and the leg, neuropathy, right? And every day, if you live in a pain score of 5, 6, 7, that means you have moderate to severe pain. And if, let's say you're not a surgical candidate, but you've tried a lot of things, then spinal cord stimulator is the answer for that. But you don't have to rely on too many medicines. Then there is an option out there which can be considered early on in the algorithm. Next slide. Again, I don't have to go through the entire FDA approval, but it's a non-drug therapy. It is covered by most insurance plan, and every day there's a dramatic improvement in technology, right? And so it can be personalized. So you can personalize the parameters of the pain pacemaker for different patients. And that's what we talked about, right? That no patient is the same, no pain is the same. And so that's why personalization is very important. Next slide. How does it work? Basically, you have a pacemaker here. If you see in the slide, you have pain signals going to the brain. And what it does is it actually creates a variety of electric impulses, right? A very different, unique waveform or unique electrical pattern, which is a little bit more stronger than the pain signal. And what it does is it allows the brain to block the pain signals and adopt the pulses which we are stimulating our nervous system with. So that pacemaker creates certain pulses, which is going to block the pain to the brain. And that's why people feel good about it. Next slide. Well, how do you know if the trial has worked for you? So let's say you say, Dr. Mehta, I did the trial, but I don't know if that's what I expect. Well, science says that if you get 50% relief, then that's a positive test there, right? Most of our patients get 60, 70, 80% relief. If you're able to get back to your daily activities for those 5, 7, 10 days, right? Usually I'll do a trial for a week. If your need for medication is reduced. So let's say you say my trial went really well. During the trial, it never occurred to me that I need to open my medicine and to have it. And then if you're able to relax and sleep better. So these are the parameters which we all need to look for during the trial. And they're not hard to gauge because your therapy specialist is in contact with you every day when they're talking to you about how the trial goes. Next slide. We talked about personalization, right? So you can have one therapy, but what we need to really understand is that it's not just one thing which is causing pain. It could be your arthritis in your spine. It could be a bad disc bulge, and it could be spinal stenosis leading to the walker, the cane, or the shopping cart sign. Next slide. It is very safe and effective. And so there's enough data out there. If you guys are ever interested, we can hand out brochures and explain to you that it's not just because, we like to talk and we like to speak about the science. There is actually robust data out there in a clinical study that these help. Next slide. Okay, so then the question is, what's next, right? So the next step is to then dissect your pain generator. You guys have all heard the word triaging, right? You go to the ER, you're sent to a triage department, which tells you, oh, well, we'll take this person first because he's sick, and we'll treat this person in the other bay because of the other problems. That's what we do. As pain management providers, we actually listen to you. We triage your pain generators. Even though patients may come in with the complaint of back pain, we dissect it down. We dissect it down as to what is causing that back pain, and we have a separate treatment or a parallel treatment for each pain generator. And that's really what's the next thing. Don't sit on your pain and come and educate yourself about your own pain. Think about it from this point of view. If you have allergies, you know everything about your allergies. In fact, you know what to eat, what not to eat, what medicine to take, what antibiotics to take, what steroid course to take. Think about it from that point of view. Or diabetes. A diabetic patient knows everything about diabetes. They know when to eat, they know when to exercise, when to insulin, the body speaks to them. That's how chronic pain is. And so your body, once you're educated, your nervous system and your body are going to communicate and are going to tell you that now's the time to take help. So be aware of that signal. Next slide. So look, the idea today was to have a very quick interaction with everybody in the community so we can understand that pain is not something which we have to sit on, which we have to accept a part of our life. Even though pain is invisible, we can triage, we can dissect pain down into what is causing the pain. And I'll be honest with you, it's never going to happen that I'll be able to switch off the pain. But if I can follow an algorithm with the help of my patients, then I'll be able to dampen or dim down this chronic pain so that they have a life which they can lead. There's a variety of other things we can do, which we can discuss during our office visits. But this just, I think you're on mute. Lucius, you're on mute.
Here I am. Thank you, Dr. Mehta. I'm going to launch a quick poll for you guys, just 2 questions. And then we'll open up, we'll take you guys off mute, and we'll open up the chat feature. If you guys have questions, we certainly want to address your questions, and we'll go from there. So I think, let's see, Dr. Mehta, the first question, is there an age restriction for either of the therapies?
No, I mean, there is no, well, I mean, I guess if the question is how young can the patient be to get these therapies, I'll tell you, obviously I don't treat pediatric patients, but as far as the other extreme of the age is considered, no. In fact, a lot of patients who are old and maybe a little bit more sick to undergo a big surgery, like a spine surgery, this works perfectly for them. And we can actually form a team between the other surgeon, between myself and the patient and the primary care, and we can actually have a mutual discussion for the benefit of our patients.
Perfect. I don't see another question here. Let me give it a second. If you guys see that chat feature here, I'll try to open up the lines here to unmute. You can also raise your hand if you see that capability there on your toolbar. So you can raise your hand, you can, and we'll ping you, or we'll get to your question, or you can also, or use that chatter feature here. But we will, just while I have you here, we're going to be following up, our team, Boston Scientific, as well as Dr. Mehta's team at PSA will be following up with you guys. We have your contact info, and I hope that it's all right that we circle back and want your feedback on the presentation. And then if you have any further questions, we certainly encourage you to schedule an appointment or a consult with Dr. Mehta and his team. I believe tonight until 9 o'clock, as you see on the screen, there should be somebody available to take your appointment. So go ahead and use that feature if you can. The number there, 855-876-PAIN. So we got a few more coming in here, Dr. Mehta. Let's see what we got. The question was, does insurance pay for this? I'm assuming that means any of the procedures.
Yeah, so that's a good question. That's really the first question we all look for, right? First thing we want to find out. So, I'll tell you that yes, the answer is a lot of the majority of the major carriers cover the spinal cord stimulators and radiofrequency ablation. Some of them there's some prerequisites you have to fill in for spinal cord stimulators for some of the minor carriers, the smaller carriers. For Vertiflex, because it's spinal stenosis is more of a disease of the aging process. It's part of the aging process, and so Medicare definitely covers it. There are certain Medicare replacement carriers which cover it, but there are some insurances like TriVest would cover it, but TRICARE, there are some other things. It's a new therapy or a new year therapy, and so TRICARE and all these are still reformulating policies and looking at things. But we would never go and jump on a therapy if it is not covered by insurance. So that's the discussion we would have beforehand when we are kind of offering this therapy to you, any of the therapies.
Sure, good question. Dr. Mehta, next question is, how willing will the VA be to pay for either of the last two procedures? I guess that's Vertiflex and spinal cord stimulators.
Yeah, so the VA definitely covers it. There's a variety of things, right? So I think if I understand the system of the VA correctly, is number one, they want to make sure that they want to keep everybody in house with their pain doctor, which is absolutely fine. However, most of patients say, look, I don't want to wait for a certain amount of time, and I already have a pain management physician I see. So the continuity of care and et cetera, et cetera. But it is covered by the VA, so the VA pays for it. Number two, for both the Vertiflex and the spinal cord stimulators, sometimes they require specific information in the medical notes, which we document. And it's not uncommon for us to sometimes even speak to a physician on the other side so that we can do a peer-to-peer discussion for the benefit of the patient.
Dr. Mehta, another one. Can I have more than one stimulator?
Great question. Can you? Absolutely, you can. Now, the question is, sometimes I'll do a cervical stimulator and I'll do a lumbar stimulator to cover nerve pain coming from the neck and nerve pain coming from the back. And it's not uncommon for patients to have that. Sometimes you have a stimulator in, but it's not covering the entire body. There are areas which are very painful, which are not being able to manage by small doses of medicines or local anesthetic numbing medicines or injections. Then we have to resort to two stimulators. So the answer is yes. Of course, the idea is to minimize the amount of stimulators you can have to cover the areas of your pain. It's all personalization.
Sure. Next one, Dr. Mehta. I've had an RF, I've had an ablation with you. What would be next since I still have chronic pain?
Yeah, so that's a great question. And that comes down to the same concept about what are the different things in the back which are causing the pain. So let's say you've got a bulging disc or a deteriorated or a degenerated disc. You may have had an epidural steroid injection, but it doesn't do anything for the arthritis in your spine. For that, you need to have a radiofrequency ablation. Problem is, most patients, including myself, I've had those treatments too. When you have a radiofrequency ablation and maybe you repeat it in 6-9 months, it doesn't take care of the bad disc. And so the thought process is, well, I've had two radiofrequency and I still hurt. And so what we have to do is we have to sit down and basically jot down whatever the pain generators are. And we have to, unfortunately, maybe repeat those simple treatments either once in 6 months or once in a year to allow the pain to dim down. So that's a discussion I'm definitely open to have at our next visit. But the things to remember is that treatment of one doesn't really help the treatment for the other.
Sure. Dr. Mehta, good question here on Vertiflex. If I've tried the spinal cord stimulator, I'd also like to try the Vertiflex. What would that be suggested? What would be next?
Correct. So great question. So, simple things here as a patient, you need to know, do I have spinal stenosis? And your MRI will say that. Your MRI will say that. You don't have to be a scientist to read your MRI. If you have spinal stenosis, it will tell you there's mild or moderate or whatever. So that's first thing. Number two, do you have these symptoms? Do you need a shopping cart? If you lean forward a little bit, does it help you? And then number three is the fact that, let's say if you were to bend or sit down or rest frequently, are you then able to continue your activities for the next few minutes or whatever till you have pain again? And if the answer is yes to all of these things, then we can go through the algorithm and see if your insurance carrier approves it. And if the answer is yes, absolutely.
Okay. And then two more, Dr. Mehta, just to be respectful of everybody's time. There are questions coming in. We certainly appreciate them. And we certainly encourage you to also schedule an appointment with Dr. Mehta and his team, right, to address these questions and see him, face to face on a more personal level. But Dr. Mehta here on, the question is, are the surgeries performed in a hospital? That's a good question.
Well, the surgeries can be done in a hospital. We do it in a surgery center, which has got operating room, and it's smaller and it's sort of, that's where my team is, and it's more convenient. And in the surgery center, you have 2 operating rooms. You follow the same guidelines as the hospital, but it's much more quicker. It's you're basically in and out, and it's a little bit more smaller and more than a hospital where you have to check in and get on a list and do other things. We still do the same pre-operative labs. We still do the same exact workup, and it's been done. But if there are certain insurance restrictions and it has to be done in a hospital or a local hospital, I'm on the panel for a lot of hospitals around the area, and absolutely it can be done over there also.
Okay. Last one here. Vertiflex, helping with dizziness. Patient said that they believe they read that in a pamphlet somewhere. Can Vertiflex help with dizziness?
No, I don't think so. I understand the question. I think if the dizziness is because of the fact that you cannot stand or walk for long, then that's the problem. We can definitely explore and help connect with your local physician to find out what the dizziness is from. But if there is no obvious cause of dizziness and that's what's leading to dizziness, then we can help that part where we can help you be more functional.
Okay. I think that's it, guys. I really appreciate it. I know the questions are continuing to come in, and without taking up your evening, we want to let everybody just be respectful of their time with their, at home with their families. Dr. Mehta, thank you so much. Appreciate your time.
Absolutely. Thank you very much. And thank you to everybody for partnering with us.
Yeah, of course. Guys, so signing out, Lucia's here, Boston Scientific. You have the contact info for Dr. Mehta's office there at PSA and Killeen. Please reach out, schedule an appointment as needed. And again, thank you all for joining us. I know it's a little bit difficult with the Zoom and doing this online from home, but we're very grateful that you joined us and were able to participate in the Dr. Mehta's presentation here. So thank you again, Dr. Mehta, everybody else, thank you so much. We'll sign out.